Hello, this is David Wallace, the PV reporter, reporting from ASH 2018 here in sunny San Diego, California. And today we're here with Dr. Michael Grunwald from the Levine Cancer Institute in Charlotte, North Carolina. It's a pleasure to have you, Dr. Grunwald.
It's a pleasure to be here. Thanks for having me, Mr. Wallace.
Absolutely. I wanted to investigate a couple of abstracts that you were involved in and kind of get your input and ask you a few questions. So if I may, I'd like to start with the first one. And this one's talking about the real-world risk assessment and treatment of patients with myelofibrosis at Community Oncology Practices in the United States. So Dr. Grunwald, if you could tell us a little bit more about this study and carry through for us on this.
Yeah, sure. Risk assessment of myelofibrosis patients is very important, and the NCCN guidelines has risk assessment as part of not only the way that patients receive their prognosis, but also as part of the way that treatment can be determined. And so at diagnosis, myelofibrosis patients should have their IPSS scores determined, and then what treatments might be best for them can be sorted out, not entirely, but at least can be helped to be sorted out with this risk assessment. And so lower risk patients who have uncontrolled myeloproliferation might benefit from hydroxyurea or pegylated interferon in some circumstances. As you get into lower and intermediate 1 risk patients, they might benefit from cytoreduction if they have uncontrolled myeloproliferation, whereas if on the other hand they have uncontrolled symptoms, they might benefit from ruxolitinib for symptom control. And then as you get into the intermediate 2 and higher risk patients, they require more definitively treatment with ruxolitinib. And a lot of times for intermediate 1 and above, we'll consider not only ruxolitinib but also consider allogeneic stem cell transplantation. And what we found in this study, looking at nearly 500 patients and reviewing charts, is that many patients are not having risk assessment performed. Mm-hmm. Many of the patients who are having risk assessment performed are having it done incorrectly. Sometimes it's being done just based on the clinical impression of the provider and not based on the IPSS score. Okay. Sometimes it's based on the DIPSS score or the DIPS plus score instead of the IPSS score. And then sometimes, even when there is a score, it's incorrect, and the score will underestimate or sometimes overestimate the risk of the patient, and this runs the risk of allocating the patient to perhaps an inappropriate treatment sometimes.
Okay. Thanks for sharing the synopsis on that. There were a couple things that I found pretty eye-opening. So there was quite a high rate of incorrectly classifying patients, more than you would expect, right?
Yeah, more than one might have expected for sure, and seemed to be a little bit more on the underestimating risk side rather than the overestimating risk side, which I thought was interesting.
Okay, so let me ask you this, as you know, the patient view, well actually it's for the whole community. So what can be done for MF patients to more accurately have their risk stratified at diagnosis? Does that mean that they're at a better center, they're seeing a better doctor, or let's say they start local? You know, how does that happen? Or how can it happen?
I think that being seen at a specialized center might increase your rate of having this risk assessment be performed correctly, but I also think that the folks who see MPNs a lot need to do a better job of educating physicians who see MPNs less often about how to risk assess patients appropriately, because I think most community oncologists do a terrific job taking care of patients, and they want to be even better at it. And I think that they're able to learn how to do a risk assessment. There are online calculators and other tools available that can help them. They just need to be aware of them.
Okay. All right. So I guess it's just a matter of further educating the medical community.
That's what I take away from it, yes.
Okay. All right. Makes sense to me. Cool. Okay, so the next item we're going to cover is patient-reported financial toxicity in acute leukemia. So I saw the abstract and I'm like, okay, I know that's not MPN, but I also know because I speak to a lot of patients and there are multiple gripes, but financial is probably the top three that I hear. And so if you could tell me a little bit about this study and if you see a crossover between the MPNs or perhaps maybe one or two of the MPNs.
Yeah, this is a study that was really led by my colleague Greg Knight, Dr. Knight, in our leukemia section. And he was interested in looking at whether patients' self-reported financial stress correlated with their outcomes, and it seemed that outcomes were worse in patients who had the most financial stress on account of their treatment. And oftentimes I'll say that if a patient was not poor before they got leukemia, that getting acute leukemia will make them poor, because not only will they have to pay for expensive treatments, but oftentimes patients are unable to work. Sometimes their family members are unable to work because they have to support the patient in terms of taking them to and from appointments and just giving care to them. And so I could see how very easily somebody who is getting along okay might not get along okay as soon as they develop acute leukemia. And there are multiple aspects to the cost, and it's only getting more expensive.
Right.
We have the cost of inpatient hospitalizations, we have the cost of infusion center treatment, physician visits, and then the increasing cost of drugs. And as more oral therapies become available for acute leukemia, I think that it will be interesting to see how that impacts the cost. I imagine that it will increase the overall cost of care.
Yeah.
In the MPNs, we have ruxolitinib, which is an expensive medication, and then we have pegylated interferon, which can be administered in an infusion center or at a patient's home. And we have a host of other drugs that tend to be less expensive as well. But I anticipate that we're going to, over time, have an increasing number of therapies, especially oral therapies, available for MPNs, which is going to increase, I think, the cost burden.
Okay.
Finally, as we get better at treating diseases, whether it's acute leukemia or myeloproliferative neoplasms, I think that the prevalence of the diseases is going to increase because patients will be living longer with disease, unless we figure out a way to cure the diseases, which would be the ultimate goal. And so as patients are living longer with their diseases, there are going to be more people out there who are taking medications chronically that are very expensive to support themselves. And as they're taking these expensive medicines to keep them going, that's going to increase the length of time that that things are very expensive and financially stressful for them.
Okay, all right. And just speaking as a patient and having, on some expensive medications myself now, one thing that many patients aren't aware of, and I know doctors like yourself will make patients aware of, but I see a lot of newbies and they hear about the cost of drugs, and that's the first thing I hear is like, oh God, there's no way I can pay that. And then I'll mention a foundation like the PAN Foundation or Insight Cares or Cancer Care or one of multiple organizations that are out there that will actually pick up the copay. So there's really a lot of different resources that are out there that I don't think patients are aware of.
I think that's true, and I'm very fortunate to work at a center where we have a dedicated staff that helps navigate patients through that process. At some institutions, It might be a Nurse Navigator who helps find foundations to assist with the cost of oral medications and other medications. And at some institutions, it might be a pharmacy tech or pharmacy liaison who helps, and we're fortunate to have both at our institution. And I hope that becomes an increasing trend over time, where oncology providers have resources that they can empower patients with to navigate this process.
Okay, so you brought up a point that was interesting to me, because I've heard about the Nurse Navigator, and I may have seen one perhaps in year one, and I can't remember because I'm 10 years in, but if I was a new patient coming into your office, would I actually see a Nurse Navigator? Or tell me a little bit more about their role.
Yeah, so there's been some research out of our institution showing that navigation helps patients' outcomes across a number of different cancer types.
Mm-hmm.
And the Leukemia Nurse Navigator is something that's relatively new in the past year to our practice, to help both with acute and chronic leukemias, the MPNs being kind of in that chronic leukemia category. And what our Nurse Navigator will do is she will try to meet most of the new patients when we see them, especially if the patients are patients who are going to be followed longitudinally at our institution,
right,
rather than a second opinion where they might just come once and then go back to wherever they were receiving care before.
Okay.
And so if there's somebody we're going to follow, she tries to meet all of them. If she happens to miss them because she's out or she's seeing another patient on that given day, she's available to catch up with them by phone, and then we'll get to know them over time. So we try to have our Nurse Navigator meet everybody who's coming in and being followed longitudinally. Not everybody gets to meet her on the exact first visit,
Sure.
but I think that would be a goal. For example, if we had 2 Nurse Navigators,
right,
we probably would be able to have every single patient navigated from the beginning.
Okay, all right. Well, that's good to know, because I was familiar with a Nurse Navigator from a terminology standpoint. Didn't really necessarily know exactly what he or she, would do. So continuing on, a little bit off topic, but nonetheless, it's in the expanded topics of MPN. I did see you had some studies on allergenic stem cell transplant. Was any of that around MF, or was it more AML? Right.
Yeah, most of my work in research for allogeneic stem cell transplantation has to do with acute leukemia. We did have one study this year as a group from our institution where we looked at patients undergoing haploidentical or half-matched stem cell transplantation, and what their rate of hemorrhagic cystitis or bleeding from the bladder is. And these transplants were performed across diseases. It was not only acute leukemia, it did include a smattering of myelofibrosis patients, also patients with myelodysplasia, some patients with acute lymphocytic leukemia, some patients with lymphoma. And what we found is that the haploidentical transplants or half-matched transplants seem to have a little bit of a higher risk of hemorrhagic cystitis, again this bleeding from the bladder, than matched sibling transplants did. And then the question is there some sort of immune effect of the half-matched transplants that's causing the bladder to bleed more? Because both of the groups, both the haploidentical group and the matched sibling group, received post-transplant cyclophosphamide, which is known to predispose to bladder bleeding. So it seems like there's something special about the half-matched transplant.
Okay, all right, very well. Well, I appreciate you giving us the lowdown on a couple of the studies that you're involved in, and look forward to new discoveries coming into the NPN world.
Yeah, thanks very much, and it's been a pleasure speaking with you, Mr. Wallace.
Okay, same here, Dr. Grunwald. Thank you.